during the public comment section of our meeting. Um, and as a reminder, the comment materials, if there are comment materials not acceptable during a public comment, but may be requested on a later agenda, that can be accommodated as well. Okay, well, we are going to get going into our agenda, starting with a program update from Katie Gentry.
Thanks, Adam. Quick updates from Homeless Services. If you have not yet seen our RFP queue is live, that it went live about a month ago. It's due April 6th. If you are not qualified under Multnomah County and are interested in being a contracted agency of Washington or Clackamas counties, you need to reapply for the RFPQ. If you did this, you probably last applied in 2023. And applying for this will get you the availability to contract with county services for the next 5 years through the end of the measure in 2030. So it is a requirement. Any contract that we release or RFP that we release, you have to be on the RFPQ list to be able to apply for that funding. There are 5 categories, bunch of information on our website through the OpenGov procurement portal. There's also a recorded session that they did, an info session that they did about 2.5 weeks ago. If folks have questions, feel free to jump on there and submit those through the procurement portal, and we will be getting those answered. Other quick updates coming from like an RFP perspective, we have an RFP releasing mid-March, specifically looking for case management for a site-based project in Forest Grove. That is forthcoming. The project will not open until 2028 or 2029, but we are looking for a provider to run case management services, really focusing on behavioral health providers, and that will go live middle to end of March and be open through the middle of April. So stay tuned for that. If you are interested, it will also go out through the HSSN listserv and be on our procurement portal. The last big update that I have is 2 projects that are happening that are in the stages of community engagement. Our permanent pod site location, the Central County Safe Rest Village, say that 5 times fast. That is opening in late spring, early summer, and we have started community engagement with that in the community that it is impacting. It's in kind of central Aloha-ish area. The next meeting for that is going to be in April. We had our first meeting last week that went really well, and then we will have 2 more meetings to work through the good neighbor process with our partners and neighbors in the area. And simultaneously, we're also doing that same process for our Cornell Road recovery project, which will open in October. The next meeting for that project will be at the end of March. So if folks are interested, you're welcome to look at our website. We have holding pages for both the Central County Safe Rest Village and for the recovery-based transitional housing, as well as the Forest Grove PSH project. So if you Google Washington County, you will very quickly find any of those projects if you are interested. The last big thing to know with contracting with Washington County, if you are a contracted provider, we will be getting contracts out at the beginning of May, similar to last year, to be kind of moving through the process to get them signed by middle to end of June for a July 1 start. So know that those are coming. Our staff held a supervisor workshop 2 weeks ago that really looked at performance metrics that are going to be incorporated into those contracts, and those will be forthcoming, and staff are working through finalization of budget and contracts over the coming month and a half. That, I think, is all from Washington County, unless anybody from Washington County staff have anything else to jump in and share, but happy to stay on and answer any questions that folks have.
Thanks, Katie. It looks like Cameron has a question.
Morning. I've just been following along with like the Metro Council kind of updates with the RPOC. That is, I think, starting in April if all goes well. And I know that they've been really tasked with performance metrics. So I'm wondering if because like timing, right? So like RPOC gets seated in April, contracts start in July. That's not a big turnaround time, and I don't even know if RPOC is really going to be able to determine like the specifics of those metrics kind of thing. So I'm just wondering, especially because contracts need to be ready by July 1st, but all the talking happens before then, if um, it's being like informed by this like hurry up kind of thing that's happening right now, or if it's kind of being informed by like the discussions that have been happening kind of all along that are not fully set yet. Does that track?
Yeah, thanks, Cameron, for the question. I'm going to take a step back. RPOC is the Regional Policy and Oversight Committee that Metro is launching. It is a new committee to replace the Tri-County Planning Body and the Oversight Committee. It is a 22-member committee with 18 voting members and 4 non-voting members. It's a combination of 10 elected officials, 8 service providers, and like community development corporations and leaders, and then folks from TriMet, philanthropy, things like that, a justice representative. We anticipate hearing kind of the makeup of that committee, kind of the list of seats has already been approved, but who is in those seats has not yet been approved. Metro anticipates bringing that to their committee in the next kind of 2 weeks, which is at what point the county will hear, and we will get that information out to folks. Their first meeting, as Cameron, you mentioned, is in April with some onboarding ahead of that. In December, there was a resolution moved forward to Metro Council about kind of the regional key performance indicators and key economic indicators, so KPIs and KEIs. Those were informed by metrics that we already have in our contracts, and we are working to set a baseline for those metrics and then improvement metrics for year 6 through 10. So yes, Cameron, that is probably going to be a topic of conversation. We are already, I think there's already like pretty consistent alignment with our contracts with what that looks like. And I think the key for us first is setting those baseline metrics in partnership with Metro and the 2 other counties so that we have something we are working off of. Difference between key performance indicators and key economic indicators are what's in our control versus not in our control. So key economic indicators, more people are experiencing homelessness, cost of housing is increasing, evictions are increasing, those types of things, versus key performance indicators, things like retention and length of time in shelter, those things that are more within the control of the homeless response system. Karen, did I answer questions or help at least give some directional alignment to that question? I would say
Yeah.
also a lot is still up in the air.
Yeah. And I think that was kind of like the impression I've gotten is that there is a lot up in the air, and like the hurried effort to try and like get stuff like nailed down in a like respectful kind of way as again like service providers who could somehow be in corrective actions because of these kind of things. So like when it's getting decided, how it's being informed, those kind of things. So happy to hear that there's what we've already kind of been doing, determining what the baseline is to begin with, and then really kind of focusing on starting there before adding in all the other stuff. Just kind of excited to hear that things that are happening at the metro level are already kind of getting in to the nitty-gritty of our county levels.
Great, thanks, Cameron. Thanks for the question. We're going to go ahead and move forward into our presentation this morning, and we're going to be diving into a topic that actually came up as a question from our friend Cam at Project Homeless Connect a session or two ago about health, housing, and medical discharge. And so we've got a team who's going to be presenting, and I've got Ruth listed first on my list, but I'm not sure which of you, hi Ruth, is going to dive in. But yeah, welcome. Thank you for being here.
Thank you all so much. My name is Ruth Atkins. I use she, her pronouns, and I work at Metro. I'll be mainly leading the presentation, but I'm joined here by my colleague Kelly Horvath on the regional alignment team at Metro. And then we've got sort of some special guest stars, Adam Peterson, one of our key partners in this work from HealthShare, I think Adam has to hop off at 9, so hopefully we'll get to an opportunity for him to chime in when we kind of do an overview of what we're working on. And then Yoni Khan is here from Northwest Pilot Project, and Yoni leads the Health Housing Integration Provider Work Group. Also served on the Tri-County Planning Body, as did Cameron. So a big appreciation to y'all and appreciation to the invite to come today and share about what we're doing on the regional alignment team. So let me see if I can get this going. Okay, can y'all see that okay? And I'm going to go through a fair amount of kind of background information, but we really want to just please chime in, raise your hand if I'm not able to see the chat or your raised hand. I'm asked colleagues or the Washington County team to just let me know. Happy to pause to clarify things. And we have built in a pretty, points of where we really want to engage in dialogue and discussion with y'all. So just again, appreciate the opportunity to be here and share what we're working on in this space and hear from you all about what you're experiencing and what you feel would be helpful to help try to address these really long-standing challenges. So yeah, I'm going to be doing a little bit of a level set around what is this regional health housing alignment work and how does it fit in. And then the invitation from the county team was around like talking about the hospital discharge challenge in particular. So we'll spend some time on that. And if the time allows, it'd be awesome to just touch on behavioral health care resource work group that's part of our work. And then we'll wrap up with sort of again, engaging you around what type of opportunities have you had, would you like to have, and we'll ask Yoni to come in and help kind of facilitate that part. Any questions or anything before we get started? Okay. So we've already sort of touched on this a little bit, but as probably most of you know, and Yoni and Cameron know all too well, the Tri-County Planning Body, part of the SHS measure, guides investments from the Regional Investment Fund. That is 5% of the Regional Investment Fund that is set aside for regional innovation. And one of the 6 goals that the Tri-County Planning Body set a few years back was the goal you see here around alignment and partnerships with healthcare systems to meaningfully benefit people experiencing homelessness and the systems and the people, you all, who serve them. So this regional implementation plan is on our website. In fact, I should have included the link to that, but we can do that when we send out the slides. But it was approved by the TCPB almost a year ago. And the planning group who kind of came up with the original plan was included Metro team. And then we've got awesome health and housing integration teams in each county. So Leslie Gong and Ben Jacob have been just amazing partners here in Washington County, as well as other folks in the county, and then their counterparts in Multnomah and Clackamas. And then HealthShare, our coordinated care organization, Medicaid partner, has been integral to this work. But we're still in early stages of this work because it is so vast and so complex and hard. So we're making progress, but we're building out the tables. So you see here again, like Metro is the convener, the coordinator, the funder for this regional healthcare alignment work in partnership with the counties, their health housing teams, and HealthShare. And each county, of course, has additional things they're working on in their own county. And then we're bringing in more partners. We're bringing in the healthcare plans, the hospitals, the other coordinated care organization, Trillium, much smaller than HealthShare, but also a critical piece for those folks who are members and get their Medicaid benefits through Trillium. And then an array of different providers. And Adam, I can pause here. I know you have to hop pretty quick. Did you want to weigh in at all on HealthShare's role here?
Sure. Thanks, Ruth. As a partner with y'all, the counties, Metro, we're really working to find ways to connect with folks who are in the homeless services system, some of which are health share specific and others of which are not. Like our cross-sector case conferencing, which I've presented to this group before, is open to people of all insurance types. And so those would be people who are on the Oregon Health Plan, those who are on Medicare, those who are uncovered at all. So when I'm talking, if you have questions about like, does this qualify for someone I'm working with? Know that some of them are going to be what we call insurance neutral, meaning that anybody qualifies, and then others are going to be a little bit more like health share specific. But just know that we're really working across sectors, across partners to try to just create better outcomes for a lot of the folks that you're serving.
Awesome. Thanks, Adam. So part of the Regional Investment Fund, the budget, the resources that have gone into this work has been having health housing capacity, the amazing team in each county that has giving the counties the capacity to participate in this regional work as well as the county efforts. And we're also funding actually through Metro administrative dollars to get into the weeds a little bit, but we're also funding the team at HealthShare that is, for the first time, there's a health and housing integration team at HealthShare, and Adam is the amazing leader of that group and that effort. So it's pretty exciting that with a little extra capacity, we can begin to start to get some traction on some of these longstanding challenges. We have a long ways to go, but we are making exciting progress. So Adam touched on this a little bit, but why are we trying to do this? We all know health is housing, housing is health. You can't have one without the other. But more specifically, we're really focusing on making sure or trying to ensure that housing and service providers are getting the information and support you need to connect participants to their health care and get their unmet needs addressed, help you navigate sort of the Byzantine world of healthcare. And that's really the core of the cross-sector case conferencing that I think many of you are probably participating in. And we also are the hospital discharge, longstanding pain point. Can we figure out some more coordinated ways to support folks and support folks not only at the point of discharge from the hospital, but ongoing after they leave the hospital? Adam and the health share team, we have the highest acuity needs folks are being, we need to be better served by both systems, right? So there's a lot of work and effort at health share and with all our partners around that population. Obviously, we all want to make better use of our resources. And even though this is a time of crisis, we can innovate and partner better to get through it together, right? We have the relationships that we're building and the pathways to be able to not be stuck in our silos. And obviously, better health and housing outcomes is what it's all about. Now, the next slide, bear with me. We wanted to try to put depict all of the things that are part of this regional healthcare plan in one slide. So it's a lot, but this again is like an overview or an attempt to give an overview. And of course, all of these strategies, there's many other tables and efforts around health and housing that we aren't engaged in. We were trying to hone in on where we felt there would be the most bang for their buck. So one way of describing this is that we're looking at access to care, right? Again, how do we get folks connected to the healthcare that they need? And again, we have also an aligned focus on the highest acuity population, as well as meeting the broader needs. So everything from getting folks the eyeglasses that they're entitled to, all the way to the folks that are the most complex that we really need to lean in and work on together as our shared patients and participants. Again, hospital discharge has been a key challenge. So we're trying to focus in on seeing if we can get any solutions there, and really just building that muscle for health housing collaboration. This is something that everyone across the country has been working on for decades, and we want to be able to have it not be something that takes, like Washington County started the case conferencing years ago. You all were the pioneer, and it took us, I believe, I was working at Kaiser at the time, helping to design the pilot. It took us, I think, 2 years to get the permission to be able to even start case conferencing. So we want to speed that up, right? And that's what Adam and his team are helping us with. So within these sort of broad areas of focus, obviously, again, it's all about improving housing and health outcomes through that cross-sector collaboration and at multiple tables. Some would say too many tables, but we're trying to align and again make better use of our resources and reduce staff burnout, make it a little bit easier to do the job when you have some answers and a place to go. So within the access to care, we've talked about the health housing case conferencing was kind of where it's began this regional work and is sort of the cornerstone, and that's happening in each county under Adam's leadership and with all our county and provider partners and healthcare partners. Um, Under this administration, we have some pretty horrific Medicaid policies coming down the pike and huge efforts at the state level and the coordinated care organizations. And we will be working with HealthShare and our county partners and all of you to support how can we, mitigate the harm that is coming from these policies around work requirements and reauthorization and burdensome paperwork. And so more to come on that, but just to know that that's really on our radar as something that where we can use build the groundwork that we've laid in these various partnerships and tables, we hope will help us again mitigate the harm from these policies that are coming down from the federal level. We're going to talk a little bit today, if we have time, about behavioral home health benefit access. That's something we're working on with the counties, and it's a state-run program. Under the aligned focus on the highest acuity population, this, again, HealthShare has an array of clinical and interventions for this population. There's a whole other presentation we could do about that, so we won't get into detail today. And also, I know Adam has to hop, but just know that there's considerable investment and work happening in the healthcare system. And then it's folded into this regional health housing integration. And then Kelly Horvath, my colleague, is leading a pilot in Multnomah County, specifically around coordinating and supporting folks who are being discharged from inpatient psychiatric hospitals. That is Providence Inpatient Psychiatric and Unity. And so that's a pilot that is just launched. The first person, I believe, was just referred into that from the psychiatric unit, and Adam again is critical in that, along with Multnomah County and other partners, and that's something we hope to scale in the future, but we're starting very small.
We're at two people now, Ruth. We're at
Two
two. We've
people.
doubled our
Woohoo!
pilot participation.
Okay, that's awesome. And that too obviously gets to the hospital discharge. So it's both, the highest acuity folks, but also the hospital discharge piece. We'll be talking more in a moment about the medical respite tables and efforts. And then under the collaboration sort of more broadly, HealthShare, again, through Adam's team and the investment that we've made as a region, now has partnered with each county to have a HealthShare and HMIS data use agreement, data sharing agreement, and the governance and the sort of protocols that are around that. And so that puts us on the cusp of some pretty exciting opportunities to understand better where folks are falling through the cracks, what are the outcomes, what are the interventions that work best. And Adam, I know you do need to hop, but do you want to say anything briefly about the opportunity here with this data sharing agreements that you've secured and the county through county partnership?
Yeah, happy to, Ruth. And I've got another 10 minutes, so we're good. You got me for 10 more. We are one of the really exciting things that's happening right now is that HealthShare and each of the 3 member counties, which is Washington, Clackamas, and Multnomah, have signed data use agreements in order to be able to share HMIS data and pair that with healthcare data. And this is kind of one of the first places in the country that's doing it to this scale, to really look at what the need is in our area and who's getting served, who's not getting served, and how people are getting served by their healthcare. And we think that this is going to be a really huge advancement for us in looking at how healthcare and homeless services partner together to really create shared resources for the highest risk folks, and how we work together in order to get people what they need. And it's really exciting, and it's a really great opportunity to partner with all of you about really what the what those needs are, and then work really closely with our Washington County partners to help us look at this, to make the best use of this data and to figure out how we make the best, the use our resource in the best way possible to create the most impact on our shared member care.
Thanks, Adam. And then Yoni will speak to this later, but Yoni has been leading Health Housing Integration Provider Table, also sometimes known as the Land of 10,000 Tables, with all this work that's happening. So we'll speak to that toward the end. But this is sort of the overview of the regional work with the counties and health share and metro. So let me pause there. Any clarifying questions? Happy to go, do follow-up conversations about any one of these circles. We are going to focus on this one, and this one. And again, I can't see the chat at the moment. Any burning clarifying questions before I keep going? Okay, hearing none. So let's talk a little bit about hospital discharge. Pathways to recuperative care, also known as medical respite care, and then shelter and housing. So we've put on there a definition of medical respite for anyone who's not familiar. This is, a program that provides healing and a place of and support and care for folks exiting the hospital who do not have a home to go to, and hopefully providing, like ongoing supports for their social needs, their housing needs, as well as their medical needs. And medical respite can come in a variety of settings and forms. But we're working with your amazing LATS program in Washington County. So Leslie and Ben, and then the Virginia Garcia team. Also Central City Concerns longstanding flagship recuperative care program, or RCP. Clackamas County, in partnership with the Father's Heart, is launching a new respite program. And then, of course, the hospitals and health systems. So this is a challenging one, to be frank. We've got partners at the table and have been really meeting in good faith, but we're trying to get traction around, is there a way with these different medical respite programs, each of which could potentially have a different contract and a referral arrangement with each hospital across the region? Can we coordinate and work together in a more streamlined way that also sustains each program at a time of, again, extreme financial stress for all? There is no covered benefit under Medicaid in Oregon for medical respite care. So the current state is just really fragmented and stressed patchwork of hospital operational dollars, community benefit dollars, grants, some SHS funding. The counties, Washington County stood up LATS and has been supporting it through SHS, but we need a sustainable and coordinated way to go. But obviously getting everybody to the table and have them agree is it's challenging. So meanwhile, at the state, there's recognition that this is among the many challenges around hospital discharge and getting folks connected to care after they leave the hospital. That given that we don't have any defined benefit that will help pay for these desperately needed services for folks, there is a bill that required a report from Oregon Health Authority and Oregon Department of Human Services to come back in this August of this year with recommendations. It seems pretty likely, given the current administration, that any effort for like a statewide benefit, getting permission from Medicaid to do things differently will be a long-term effort, but that's something we want to also be working on. Think about the long-term sustainability, while in the short term, we're trying to come up with solutions to support having, a really sustainable network of medical respite options for folks in the Tri-County region. We're also at the same time getting some traction in Multnomah for basically a form of medical respite, but really at the super low end acuity end of the scale that would be integrated within an existing shelter that we have coordination, a referral pathway from the hospital, a shared funding agreement, and then ongoing coordination of care, again, like through the the coordination of care that Adam is leading. So that's what we're trying to get traction on, and it is slow and challenging. And so we really want to have the opportunity today to be able to hear from you to help us like inform this effort. The idea is the theory we have is, again, having an efficient, centrally supported system will help with the appropriate placement for patients. There's a whole array of different places and options of places where hospitals are discharging folks to. Some are okay, some are obviously not okay. And we have, yeah, again, limited resources to be able to support the best placement for folks and really to be able to build out that system of care. We know a zillion studies have shown that if you are able to provide appropriate medical, respite, or recuperative care, that will reduce the total cost of healthcare and improve outcomes. And this needs to be a shared cost, but that's a difficult conversation, right? We have to have that appropriate placement of folks and a shared funding model that is sustainable. So with all that context, now we wanted to have a discussion pause here and really invite folks to weigh in. Here's some questions. Welcome to address any of these that speak to you, but wondering about, your biggest pain points. We know that discharges from the hospital for folks experiencing homelessness is a long-standing pain point. So what's happening right now? Are there any bright spots or better practices to lift up that you can share?
Ruth,
And
I'll just add there's a couple of questions popping into the chat if that's helpful.
okay,
I don't know if you can see them. But
yeah.
one from Kathy Nelson is what percentage of the time are people discharged without any of these services being in place, basically to the street? And then
Mm-hmm.
another question after that, if you want to address the first one.
And
Yeah, absolutely.
I was starting to put the written answer in the chat, but I'll answer Kathy's question, in that it's actually a really hard thing to track because
Mm-hmm.
every hospital does their discharge planning a little bit differently, and there's not a consistent way of being able to say if someone was discharged, where discharge location is, and not every hospital has the same list of like someone going to somebody's home may be tracked differently, and somebody being discharged to a shelter and whatnot. So it's actually a number we don't have a ton of insight into, other than we know it's a lot bigger than we want it to be.
Yeah, and that's part of the piece of, can we, rather than each hospital doing their own thing kind of in a silo, and to give them credit, their discharge teams are working really hard to try to not discharge people to the street. Um, Nobody wants that, and we don't have a coordinated system. And so each hospital is kind of, doing a variety of different things, but can we agree and come together on some shared resources so that we can then also keep track of folks and not have them, that we can, get them connected into that through that cross-sector case conferencing, for instance, so they have their ongoing needs met, even if once they're stabilized after their hospital stay. I see Tim chiming in, talking about in your family shelter experience. So I'm just reading what you said, but Tim, but if you want to just share anything about that.
Yeah, I can probably summarize. I guess the thing that we are pretty regularly trying to navigate and improve like our response to is when families are discharged from a hospital and then get referred directly to our shelter building. And we're here in Tigard,
Mm-hmm.
family shelter here in Tigard. Um, that this is like a small percentage of the folks that we serve, but with that small percentage of folks that we serve, we're seeing that like even with a rent assistance program, sometimes that's not adequate for that person to go and live in housing on their own. So it's not adequate for that person to be able to leave the shelter and uh, conduct their activities of daily living on their own and just kind of sustain housing on their own. Um, so I guess I just wanted to highlight like that as you brought it up, just that gap in services for the folks that maybe need a longer term like longer term medical services, but also longer term kind of like shelter services. Because I think what we are seeing now, just as the from our shelter perspective, is that these families with like maybe I don't know the exact terminology, but maybe like medium acuity to high acuity medical needs um, are entering our shelter, and then what's supposed to be a temporary, like our whole program is built to be a temporary housing solution before a person moves into stable housing. But we're seeing that our shelter uh, is kind of needs to be what is like the permanent housing solution for some of these folks entering the program, just because they need that level of support with like cooking and keeping the lights on and paying utility bills and all of that, which we cover here at the shelter building. Um, but again, it's supposed to be a temporary solution, and we're just seeing that there's not really a good spot for like all of the people with that level of medical need to go after shelter. There are some spots that meet those needs and like some programs. And one of the things I want to highlight is that ACT program, assertive community treatment. I don't know the term again, but yeah, whenever there's a support group around a person, we see that person succeed a lot more frequently.
Hey, Tim, I'm just curious, so some of these folks, are they making it to cross-sector case conferencing?
Yes.
Yeah, okay. And the need identified needs are not getting addressed in that space.
I mean, I would say as services are available, they do get met. But I think we're just running into like the level of need is higher than the uh, amount of services that are available, which is just kind of this more of the same that we all know. So
Got it. Thank you.
yeah.
Yeah, yeah. Thanks, Tim, so much. Yeah, and I should have said along the way here, like with all of this, we're not trying to ask SHS providers to become experts or let alone medical providers, right? That's not y'all's role. So it's getting you connected with the people whose job it is, and it's all in this crazy resource constrained environment. So I really
Yeah.
thanks for lifting that up. And yeah, we can't have enough of it would be awesome if we had like 10 times the medical respite capacity. Um, so that kind of gets to the long-term goal, but thanks for sharing that. Beatrice shared about a family that are diabetics and are having a hard time. So I don't know, it's certainly, the cross-sector case conferencing would be available, but I don't know if there's through the county teams, if there's someone working with them, or I'm not sure quite what resource we could offer. Beatrice.
I'm sorry. My name is Beatriz. I'm working in Adelante Mujeres. Yes, we have a family who they don't have a lot of information about where they can call or where they can go, right? So they just are asking where we can send them for try to because they don't have a house and they are working, but right now because they were evicted, they don't have a good record. It's very hard for them to place a new place, to find a new place. Sorry.
Thanks, Beatrice. I don't know if someone on the county could follow up about the housing side of things. For the healthcare, we could, it's finding out if they have insurance and who their coverage is. We could help with that to at least try to understand where there might be a resource on the healthcare side.
Just jumping in for this is Martin from the Homeless Services team with Washington County. Beatrice, I'm gonna throw it in the looks like Lindsay's following up via chat, but I'm gonna throw a good email address that you can reach in. We have a list of some potential resources that might be helpful that you could share. But yeah, I'll put the email in the chat for you, and we can connect there.
Awesome, thanks. And yeah, and Jen, just to underscore too, like the cross-sector case conferencing is a resource to figure out if there's a healthcare support that we can connect those folks with too, in addition to the.
Okay, thank
But
you.
thanks, Beatrice. And then Cameron, comparison of those who end up being shelter, long stays, and higher acuity medical needs. Yeah, again, I don't think we have like we're a sort of a data to compare it all. We are, I mean, the origins of the cross-sector case conferencing was hearing from providers that they had folks showing up in shelters with unmet medical needs that they had no way of addressing. And so that's been sort of the through line of all of this effort to try to be able to at least have a place for shelter and housing providers to go. And the cross-sector case conferencing can be for anyone who is unsheltered, sheltered, or housed to be able to connect them because there's needs all along or immediately following a hospital discharge. But Cameron, I don't know that we have a sense other than anecdotally at this point that the needs are great. Folks are getting higher and higher acuity. Of course, there's the aging population. Yeah, I think with the data sharing agreements, yes, we'll have more opportunities to be able to do that kind of analysis and system improvement because we now for the first time have healthcare data and HMIS data able to talk to each other around and to do analysis at the population level as well as potentially, at the individual level as well. All right, new things in the chat. Anything else there? Any other thoughts in general about the hospital discharge challenges? Like we put on there, like if you could wave a magic wand, and obviously we've got all the challenges that everyone is dealing with, but like what money aside, what would it look like to you to be able to have like a hospital discharge done in a coordinated fashion with the shelter and housing provider network? Anyone have any? It's hard to dream in this time we're in, but we're trying to drive toward those system improvements. Anyone have any recommendations or suggestions?
I've got a little bit of a long shot one. Oh, sorry, Kim.
You go.
Just real quick. I mean, as part, as this is again from a housing provider perspective. So, uh, here in our family shelter and in our housing case management programs, all of the work that we do before we, if we're calling a positive, a graduation from the program or an exit from program into housing, if we're calling that a discharge, to kind of share some language, we don't do that until the person is doing it, the family's doing it themselves. They've either increased their income or they've gotten connected with, a rent assistance program, something that'll allow them to move into a place for a determined amount of time, if it's a year, 2 years, or longer. Um, so I think any increased level of that incorporated into the hospital discharge process, if that's a collaboration with the housing provider, and this is, again, a little dreamy, but having that like housing sustainability, housing stability conversation as part of the hospital discharge, um, would be a useful conversation. Just asking the questions, how are you going to be able to stay in your housing for the next week, month, 6 months, a year, whatever is
Thanks,
feasible.
Tim.
Yeah, thank you.
Kim?
Kim. Um, So many thoughts, and I will tell you, I probably have some really strong feelings just because the frustration level. And recently we've just seen some really inhumane treatment, which just it is shocking more than anything. But you asked about a magic wand, so I think part of it, and Karen just leaned into this, is making sure we have the adequate services so people don't get to that point. We've been working with on Solutions Council. We have representation from TVFNR. And one of the things that, and I don't know if Kim Han is here or anyone from TVFNR, if they are, please raise your hand, is figuring out how we don't utilize the emergency room as the only place that people can go, particularly when they don't have a medical need. And how can the system support that? And what could that look like for our first responders? I mean, a simple answer in my pea brain, and I'm not trying to make it simple in terms of like, oh, that's just so easy, because nothing is that easy and there's not always enough funding. But I met with Chief recently, and he didn't even realize that all three adult shelters, Tim, I'm not going to speak for family right now, have e-beds that I believe they could be utilized by our first responders. It would take 3 phone calls. It's not a dashboard that they could see like that these beds are available and stuff, but they would have to call and think about regionally, where is the incident happening and which shelter is closest. But I was like, that's an easy step for you guys to take versus taking someone who doesn't have a medical need to the emergency room. Let's just go ahead and get them into an e-bed for overnight or a chunk of hours, and then we can figure out some next steps. And so just trying to figure out how we get ahead of it better, because I'm recognizing that we're asking the healthcare system, who is already bombarded, to do more and be part of this solution. I would love to see them not discharge, in the middle of the night at 3 a.m., someone in a wheelchair in their hospital gown and socks, and say good luck. That just isn't okay. But saying that doesn't actually help anything. And so I'm not finding the right. I'm speaking in draft form, and I apologize. It's just trying. It's trying to get ahead of it and understanding better. And I think that our first responders are a place that we could engage with more, because they're part of the traffic to the emergency room. And then we get the discharge and go, not great, not great. So I'm glad these conversations are happening. I'm glad Metro is a piece of this conversation, because it is so important. And Adam is also on our Solutions Council here in Washington County, which is fantastic to have that voice and understanding of the healthcare system. And then it's just a huge gap and miss right now. And we're frustrated, Ruth. We're frustrated.
Thanks,
Thanks, guys.
Kim. Yeah, 100%. Sorry, I'm getting distracted by things popping up in the chat. Can you describe what are the e-beds? I should know this.
No, it's okay. So at our shelters, we now have 3 shelters in Washington County for adults: Beaverton, Tigard, and Hillsborough. And the shelters have what we call emergency beds. And so law enforcement or our friends at the Hawthorne Walk-in Center or DV situations can refer to those beds. I'm going to speak out of turn here, and I know county is on here, but I also think first responders in some form should be able to have access to those e-beds, so that we are not using the emergency room for every interaction with first responders. And I also know, as a partner who has one of those shelters, our e-beds are not full every night. So there's opportunity here to kind of catch our homeless friends, instead of taking the emergency room, bringing them to shelter, and then we can start to engage and see what potential next steps are. Again, there's no bucket of gold at the end of the rainbow in any arena, but at least they would be safe for a little bit of time, and we can help conference with them to see next steps to the best of our ability. But again, I'm
Yeah.
I'm making that really simple when I know it wouldn't be, but it's also a tangible solution that I can think of right now as we talk about the system at large in a bigger way.
Thanks so much for flagging that. And we really the metro tables, we really have not by and large had first responders involved in that. Like we're just like, so that's a really great flag, and maybe that's something Leslie and Ben we could talk about in the future. And the e-beds piece is really intriguing because I don't think that exists in the other counties, to my knowledge.
Right.
So thank you for flagging that.
Yeah.
So questions are coming up. Oh, and the other piece too around there's the horror stories, and really, that Senate bill I mentioned came out of, one of those stories. And anyway, um, so we don't currently have a way to engage with the hospital discharge teams at one, let alone all the hospitals, to avoid that, especially that middle of the night piece, right? I mean, that's so, you know, figuring out how to get traction within the pressures they're on to like empty up those beds, right? Like we need to be able to have a coordinated approach, obviously. So just thank you for flagging that, because we cannot let go of it's just not okay for that to happen. Okay, so we'll get back in the presentation in a moment. But I see a few questions around the folks that really need a deeper level of care, even than PSH can provide. And that actually is kind of what we're going to touch on in the next segment of the presentation. So we'll hold that, not that we have a solution, but just what we're trying to wrestle with. Folks with serious mental illness and trauma, yeah, 100%. And, obviously there's, systemic racism, stigma, all kinds of challenges with the healthcare system as there has been with the housing system, right? And so we're not necessarily solving for every interaction, but we want to at least try to have a trauma-informed approach to how we're doing the system improvement and collaboration. But it's real, those barriers and those negative experiences, along with, again, I would say, having worked in the healthcare system, like the good faith efforts, but it's a vast system, and there's definitely negative impacts. And then April, folks cycling in and out of the ED as they don't have a primary care provider. Um, yeah, 100%. So that's the primary care connection is really at the heart of the case conferencing that Adam leads in each county. So I think to the extent, April, I don't know if you already have folks who are connected into the cross-sector case conferencing, but that's a big focus, is making sure that we can get folks connected to their primary care so they have the basic needs. So April, I don't know if you're already connected, but and we're trying to build it out because it's small scale, but we're trying to scale it up. And then Leticia has a family, the children have a medical condition. I think this is more of a county homeless services question, but again, to the extent that there could be a connection with the case conferencing to help with the medical side of it, that would be great. And okay, I think we've gotten through the chat for now. Thank you so much. Any final hospital discharge? I think, Kim and Tim and others spoke so well to this. It's going to continue to be a major focus of what we try to do in the area. And it's, even when I worked within the health system, it was like almost impossible to get traction with the hospital world. So but we're trying, we're doing our best. Okay, let me get back into the PowerPoint real quick. So shifting gears and talking about the behavioral resource piece, are we doing okay for time, Lindsay and team, if we have a few more minutes? Hearing.
Thumbs up. Yeah, you can approve. Thank you.
Okay, awesome. So the counties, this is a part of the sort of the circle of tables. The counties asked Metro to include in the regional plan kind of how can we work together to not solve for, but just better navigate or demystify at least some aspects of the behavioral health world, right? That is even one of the most complicated parts of all of these challenges. So we have a little work group with the counties and Metro, and we've been trying to work on a couple different things. One early project, whoops, let me get back in here, was a flyer we put together for SHS providers around the Tri-County Behavioral Health Support Lines. Hopefully folks have seen this. If not, we could sort of reissue it. But the idea was to clarify that you can call the behavioral health support line anytime with any question. It doesn't have to be when someone is in crisis, but they're really there for you for information. They do have some referral opportunities, but even if it's just a general question about how to support a participant, obviously it's not a complete solution, but we just wanted to make sure that at least this basic resource SHS providers knew it was out there and that there is no wrong call is what they told us. And we had thought, oh, this is a place where you call if someone is in a behavioral health crisis. Not true. So that flyer we could reissue if that would be helpful if folks haven't seen that. And then we also, HealthShare did a really great Medicaid 101 webinar. Again, we're not trying to ask SHS providers to become experts by any means, but just to have some basic tools and understanding. This was recorded and available back in September, and we're always interested in hearing from y'all about any other sort of healthcare related training, demystification topics that would be useful for you. We also have, working with HealthShare, they've got regional trainings for non-clinical folks around wound care. So I think that's opportunities to be coming up as well. So we'll be sending out information on that. So those were a couple of the things this group worked on early on. And at the moment, though, we're focused on this piece around the behavioral healthcare home health benefit. This is a benefit that the state runs, it's Medicaid. And this kind of gets to some of the questions that were in the chat about folks with the really higher needs. And also want to invite Yoni to chime in here. These are Medicaid benefits, sort of similar to long-term services and supports, LTSS, but specifically for folks with mental illness or behavioral health challenges. And in a nutshell, no surprise, it's Medicaid, right? These programs, you apply to the state. They are really hard to get access to and hard to apply for. And even once you get an application approved, it's hard to get the workforce, find a caregiver to come in. But we are, Yoni just hosted a really great meeting on Monday. We are having exploratory discussions to see, is the juice worth the squeeze, given that this is money that comes from the federal government. There's a federal match for one of these programs, so that there's resources that could be used for things like cleaning out someone's apartment, helping them with cooking. It's not like the full suite of, it's not everything that folks need, and it's not, to be clear, it's not a mental health provider, but it is the sort of in-home supports for somebody once they're housed that currently a lot of you may be doing for your participants. So we're trying to figure out, is there, with this regional capacity and this regional table, is there something we can do to coordinate or support applications to the state to get access to this benefit? And there's a lot of momentum and pressure, frankly, being put on the state because of all the barriers and difficulty in getting access to this benefit that folks are entitled to. So there's sort of an opportunity that we're also leaning in on with the regional table to see if there's process improvements, making the process easier, having some supports again for folks who would be applying. So I'll pause there. Yoni, did you want to add anything about your takeaway? And then we'd love to hear from folks if any feedback they have about any experience you might have had with this, or if you would like to learn more, if there's something that might be of interest for you to explore.
Thanks, Ruth. Hi, folks. My name is Yoni Khan. I am the Advocacy Director for Northwest Pilot Project, and we serve exclusively adults 55 and over in Multnomah County. So we, all the things that you all have been saying around higher acuity and the need for stabilizing folks in a non-clinical setting when they have medical issues that spill over are something, that is very relevant and strikes a chord with us. I think, when it comes to pieces of exploring access to different benefits, it's really important to understand, number one, the opportunities and the barriers, but also understand the exact services that could be provided here, just so you can get a sense of how you might tap in to different pieces here. The counties and Metro asked us to organize a group of about 20 service providers with the 3 counties, Metro and Portland Fire and Rescue, to kind of explore what this benefit is and how providers are currently tapping into it and what would need to change. And I think, the most important thing here is when we undergo an analysis of this, we really want to make sure we're doing it from a client-centered lens. We're doing it from the lens of this is the client's journey, here's what they're encountering, here's how it's impacting staff. Because I think that ultimately is going to be part of solving the solution, identifying the solution to a lot of these things. Ruth really did a good job setting this up. The 1915I are wraparound services that include grocery bags, transportation, employment training, and between 20 and 160 hours of personal care attendant, so a home health aide for individuals who qualify. In order to qualify, you need to have severe and persistent illness diagnosis, plus some sort of an engagement plan at the current time. I think there's a lot of acknowledgement that it's just really hard to access. But here's the kind of the opportunity. From a funding level, I know that my agency is paying for a lot of things like muck outs for clients who are very high acuity. We're also paying for personal care attendants using unrestricted SHS or private funds. We're utilizing a lot of resources on transportation. These are all things that could potentially be covered under this 1915I benefit. So in a world where things become more streamlined, there's absolutely an opportunity to offset local costs that are currently being, like dollars being used from the SHS pot, to offset a lot of those costs by pulling down resources at the federal level. That, in theory, if you can quantify it, helps alleviate the budget gap that the counties and all of our funders, whether it's Multnomah, Clackamas, Washington, or Metro, they're all kind of grappling with their own funding deficits, which obviously has a link to our ability as collective providers to give services. So the idea is if you can harness a benefit that is able to provide services, the real opportunity is you can offset costs that then get reallocated to other things. I think in order to do that, we really need to have a lot of conversation on what are these barriers, how are providers in each county expected to access this benefit so that at some point you do see that financial return to open up a little more resource. But really what I want to drive home here is we got a lot of folks, at least in my agency, that are struggling to retain housing after they're placed. We often work on a system, where we're using self-reporting to identify a level of need, and the client is not always able to articulate that. And so oftentimes these issues present themselves in a housing setting without much notice, and then we have to kind of scramble before a catastrophe happens. In this world, there's levels of acuity as we've discussed, and I think that it's a real need to have more personal care attendant, more help with instrumental activities of daily living, more help with activities of daily living. That is a real piece of the puzzle that we have yet to unlock to help stabilize folks. It is not a substitute for, comprehensive care. It's not a substitute for a service plan from the mental health side of things. But at the same time, what we're trying to do is just explore, again, is the juice worth the squeeze? These services are vital, they're needed, they're hard to access, and we're trying to hit a place where we can free up some dollars to help with budget crisis. So I'll pause there, but that's my spiel, and I appreciate being here.
Thanks, Yoni. And yeah, I put in the chat, but we can send out, maybe ask Lindsay to send out the deck for the meeting you hosted on Monday. Some of you were there, so apologies for the repetition, but that has the links. But yeah, and to Josh's question, this is my understanding, these particular benefits we're looking at are through OHA. They're for folks with mental illness, and there's been this weird siloing. There's some, looks like there's finally a breakthrough to not exclude. I get lost in the complexity of this, to be honest. But basically, the state is trying to make it easier. Traditionally, you've had to go to one place to be able to get one type of personal care attendant and in-home care, and to another place, to another agency through another whole process. And it's a little, we've, I think New Narrative, Beth is on this call, like even experience folks whose job it is work on behavioral health and navigate in these systems have found it difficult to access this benefit. So we're definitely not saying, oh, let's just do it. It'll be easy money. But as Yoni said, we want to talk to providers about if there's a world in which we do have regional resources that we could bring to bear to help support process improvement. So is that something that would be of interest to folks to even explore or consider in your organization? Oh, and Ben, thanks for the expert response to Josh's questions. Any comments or questions about this? I know it's a little bit in the weeds, but this has been such a pain point of folks needing that extra level of care in their home. And as Yoni said, like this is not folks have to already be engaged. This is not solving the mental health or mental illness side of things, but it is providing some of those supports that a lot of SHS providers are struggling to cover.
I'll just add, from my lens, what I try to do is understand what's actually covered, understand the opportunity that there is around kind of switcherooing the funding, and then most importantly, how is this going to impact the workflow for staff? And as you're thinking about that, the question is, how do you balance a potential change in workflow for staff against better access potentially to a resource that is really critically needed to stabilize folks who are either beginning or currently having challenges in their housing journey. Because the idea is you don't want to lose the investment of having housed someone off the street, put them in a stable place, and then kind of see it all fall apart because we can't get the right wraparound services available. This doesn't entirely solve that, but that's the cost-benefit analysis that everyone should take home, right? Start thinking about it because I think this conversation is coming, is just coming for us.
Yeah. Thanks, Yoni. So we'll send out we'll get the slides out to you if you want to read more about this. Happy to have folks reach out with any questions or if you want to get involved or would help just maybe get more info. Certainly the counties, this has been a priority for the counties, and we'll keep those discussions going with Yoni and other provider partners around is there a there? If so, what would be some supports that we could provide as well as engaging at the state level? Leslie, I don't know if does that sound right to you as far as next steps?
Yeah, that sounds right. And if there are spaces where you want to get involved, and where we could have more conversation, I'm happy to hear those recommendations, so that we could create that space at the county level.
Awesome, thanks. Okay, well, let's wrap up. I do have a couple more slides. This is really back to Yoni as well, but given that we have all these tables, all this work happening, and we obviously need provider input, provider feedback, and helping co-design things that will be workable for you. I think, Lindsay, we might have a little Zoom poll. Is that correct? If so, I can take the slides down again. There it is. Oh, yay, I didn't even have to stop sharing. So here's a quick survey. I'll let you all do that around your current involvement in health housing integration projects. While you're answering the poll, we started this with the counties and health share and sort of had the vision about what are the areas that we want to try to work on and improve. And we're still figuring out some of the specifics of what the strategies will be. So nothing is baked at this point. We've got a lot of pilots and then a lot of ideas. So all that to say, we really welcome and need provider engagement in all of this. So Really welcome your feedback and suggestions. And then Yoni, again, I want to give you space to chime in and just share a little bit about
Sure.
the HHI providers group. And I'll
Yeah,
stop sharing
so
again.
we have been organizing these ongoing conversations for the last 2.5 years, and it's been a lot of pivoting based on what's been happening in the world. But I think ultimately this HHI space includes about 20 direct service provider organizations representing the full continuum of services from all three counties. It doesn't mean every service provider is involved, but it means we have outreach, shelter, transitional housing providers, housing providers, permanent supportive housing. And then we have the three counties, Metro and Portland Fire and Rescue. It is a provider forum that is focused on how to streamline delivery of critical information from system representatives on things like pilots, policy and system changes that affect like how housing and homeless service providers can access healthcare, and also help get prepped for what's coming down the line with a lot of these changes around HR1, etc. And so, we were meeting monthly for a long time. We're moving to quarterly because we want to have longer meetings. There's a lot going on, and it's, important to collect information from the various, programs that are doing a lot of the work. And we want to just kind of report to folks on a regional level, hey, here's something you might want to follow. Here's a pilot on, whether it's housing, hospital to health to housing, or whether it's just cross-sector case conferencing, or whether it's what's happening in the world of PSH, what's happening with HR1. It's an opportunity to come together, get some formal presentation from different groups that are actively doing the work and working on it, and then ask questions in a collaborative way. It's not an inquisition. Everyone shows up collaboratively, and I think that's really important. We're not there to blame anybody. We're not there to complain. We're there to really identify from an operational and technical perspective where are clients getting stuck, and where is the right place, or what is the right conversation to have around how to assist them to get better outcomes, working with service providers and cross-sector, health systems, etc. So I'll pause there. I have to leave in about a minute. I'm sorry about that, but if Ruth or the counties that are on this call want to connect any provider, I'm happy to meet with you and tell you a little bit more. This is really informal, and it's really meant to just be a community of practice so that we can inform each other in times of transition about clients not getting lost through the cracks and keeping momentum on a lot of the bigger priorities, such as health and housing integration, as we're kind of navigating a lot of different things happening. So that's my spiel.
Thanks, Yoni. And just continued thanks to you for facilitating and convening that providers group. It did start in Multnomah County, but yeah, that's the goal, is to have representation from all three counties so that this is a shared space, as you said. So yeah, and thanks, Kim, for the tip about TVFNR. That's a great idea. We can talk about that and how we could include more folks at that table. I know Yoni has to go, but we'll have a follow-up. And I don't know if Lindsay, if we're able to see if we have any poll results, but we would love to follow up with anybody who is not yet involved and would like to be more. So we can do that follow-up after the meeting, and we will get you that deck about the behavioral health in-home care benefits. So thanks. Oh, I see the poll results. Okay. So yeah, looks like a good mix. All right, well, awesome. So thank you. We will, yeah, like I said, we'll work with Lindsay to get the details, and we'll continue to work with the amazing Leslie Gong and Ben Jacob and the team. Just really appreciate the partnership. It's been, it's no secret, there's often tensions between Metro and the counties at different levels, but the health housing integration work has been really just a lovely partnership. And we're all trying to we're all trying to solve for this. And I've heard this work compared to trench warfare, like you're crawling along and then you're trying to do something and then you fall back. But we all are trying to work together, and it's just been a joy. So yeah, thanks again for the opportunity to present today, and we'll also get our Kelly is going to be really the lead going forward. I'm actually retiring in about a month and a half. We're going to but we are full speed ahead on doing this health housing integration work. It's a priority for Metro. It's a priority for all of us. So just appreciate you all. Unless there's any final questions, we probably need to wrap up your agenda. But thanks again for the opportunity.
Yeah, thanks, Ruth, and Tiani and Kelly, and I know Adam popped off, but thanks to him as well. I know we're diving into a big topic, but it's worth discussing and worth reaching for solutions. But we're going to move on in our agenda. We did not have any public comments arise during our meeting today, and so we're going to pivot directly towards our announcements. And actually, Lindsay has two announcements, first on Lived Experience Committee, and then a note regarding our April HSSN meeting.
Hi, everyone. Thanks again, Ruth. That was incredible and really valuable. So thanks for sharing. Not a lot to report out on for the Lived Experience Committee. Did want to give a shout out. There's not openings right now necessarily. I think that the next meeting is in April, but big shout out to those who are in the committee and the involvement that you've had with the Metro Pilot Project. It went over very well, and there's been a lot of kudos in that space. So thank you again if you are one of those people. I want to we're really excited to announce that April 1st is our next HSSN meeting, but we are pivoting away from our Zoom learning space and going to the Public Service Building Auditorium. Hopefully everybody knows where that is. I am about to put some flyer information into the chat. So the time frame will be from 9 to 11. We're really hopeful that all or most of you can join us. It's for the No Place to Grow Old film screening, which was filmed locally here a couple of years ago. Some of you probably are familiar with the screening or have watched the film. We're hopeful that people will come and join whether they've watched it before or not. We're going to dive into some valuable discussions that in many ways are related to some of the threads and themes that we've been talking about today. But we'll have a panel discussion, a lot of opportunity for networking, and just really sharing in a space that dives into the topic around aging and homelessness and how that relates to our work in Washington County. So I hope you'll join. And then the other update regarding training is we have a new curriculum that's been developed internally from over at Public Health for harm reduction. So we're going to have somebody from over there as well as the HIV Alliance come and do a really interactive workshop. So even if you've taken harm reduction 101 trainings in the past, please check it out and register if you're able to come. It's in person over at the conference center, so we hope we see you there. I think that's all I have. Thanks, Adam.
Thanks, Lindsay. Yeah, it'll be fun. Looking forward to getting together in person. Lastly, if you didn't notice in the chat, Ruth has made an email and phone available for her and Kelly. So if you did have further comments or questions and you wanted to directly email them, they've graciously made that available. And we've come to the end of our meeting where we open the floor and encourage anyone who wants to put an event in the chat or unmute and turn on your camera and let us know of any highlights in your agency or any kudos that you would like to give. We'll provide a little space for that. And other than that, we'll be also closing our meeting. So if you need to pop off, have a good month. We'll see you in person in April.
You guys, sorry, I'm not fast enough. I'm not fast enough, Adam.
Go for it, Kim.
Our next one-day event is coming up. And it says it's unable to send file due to admin restrictions. Okay, but our next one-day event is coming up on March 13th in Hillsborough. I will get the flyer to somebody to get it out to everybody. And then Lindsay, question, Bronwyn from No Place to Grow Old has participated in other conversations. Is she coming to our HSSN meeting?
Not this time, unfortunately. We will have some other members and potentially elected representatives, but nobody from the film crew or the people that were highlighted in the film are coming. Great question. Yeah.
All right. Well, have a good Wednesday, y'all. We'll close our meeting.
Thank you. Bye.